So as Lee said, I'm a research fellow at the Manchester University, and over the past 5 years, I've been looking at primary care data using GP record electronic data sets and addressing certain mental health questions. And today I'll be talking about the paper that we published in 2018. And this was looking at self-harm in older adults, looking at the incidence, so how common self-harm is in this group, how they're managed in clinical practice, and what are their outcomes. So I just wanted to take this opportunity just to be mindful that researchers are mindful that every piece of data has a person behind it, and just that self-harm and suicide can affect anyone. And therefore, I'm just going to put up some resources of support. So next slide, please. Okay, next slide. So the outline of the talk, I'm just going to give a background of why we should consider the importance of self-harm in older adults, and the research gaps that we found before starting our study.
Cathy, sorry, just 1 second. There's a few people saying that the volume is quite low. Is there any way that you could turn the volume up on your laptop or anything?
Is that better if I hold my mic?
Yeah, that seems to be better. Sorry to interrupt.
Okay, no worries. So yeah, I'm going to look at the research gaps that we found before commencing our project, and also details about the study. And also, because this is based on primary care data, looking at some emerging work on self-harm in older adults, which might be useful for you. Next slide, please. So, excuse me. So we know suicide is a major global public health issue. And what we tend to see when we take into account regional global differences, that rates increase with increasing age. And we can see that there's a lot of focus on younger age groups. When we look at this data from ONS, which is of 2019 registrations, we can actually see in the older age group, so those sort of 75, I can't quite see it on my screen, it's on par to actually the younger age groups in men. So it is really important that we begin to look at this older age population. Also, ONS gives some statistics over trends over time. And from the beginning of when these were published in, I think it was 1981, high rates, there were really huge high rates in these older age adults. And it's slowly come down and it's stable. But over the past maybe 5 years, it's sort of been going up and down, so peaks and troughs. So there is some evidence that there is some increase within this age group. Next slide, please. So we know self-harm is one of the most important risk factors for subsequent suicide. And unlike other age groups, older people who self-harm have increased suicidal intent. So this report was looking at emergency departments of those individuals presenting with self-harm, and from 3 large hospitals in the northwest of England. And although they found repetition rates were low in older adults compared to middle-aged adults, self-harm was more often fatal in this older age group. So again, there's this real need to look at this group seriously for self-harm and suicide risk. Next slide, please. So with all these factors in mind, we can see that the projected number of individuals of age 65 years of older is set to rise by about 25%. So in the bottom 3 bars are pensionable age, and you can see that by 2045, that there's going to be this potential increase of 25%. And over the life course, there's a decline in function ability through multiple comorbid conditions. There's experience of bereavement, potential social isolation, and all these associated factors with self-harm among this older age population is a behavioural response to the psychological distress. So again, it's really important that we focus on this age group. Next slide, please. So in terms of the gaps of research before we started our study, there was limited published evidence within this age group. And but they were more based on hospital emergency departments, attendance, mortality statistics, or registered based studies. And there was nothing in primary care data. And we know that a lot of them reported on risk factors for self-harm, repetition or suicide. They described incidents and self-harm methods, but suicide was the only primary outcome. And there was just a lack of the specific clinical management detail. So we know that NICE guidelines recommend older adults must be assessed, but we really didn't know what was actually happening to this age group. Next slide, please. So this study was funded by the Greater Manchester Patient Safety Translational Research Centre, and it was published in 2018. And I just wanted to put this up so that you can see the co-authors, the research team that I co-authored with. Next slide, please. So our aims, therefore, were to get an idea of how common self-harm was in this group. And we did this by estimated incidence of self-harm in 65 years age and older, how they were managed. So we looked at their referral to psychiatric services, and also the medication following 12 months following their initial self-harm. And for the outcomes of self-harm, we examined all cause and specific mortality, specifically on natural death and suicide. Next slide, please. So the UK is a great source of primary care data, the Clinical Practice Research Data Link. And this was one of the largest databases of electronic patient medical records. And at the time, there was over 4 million active patient records. And this covers about 7% of the UK population and is representative in terms of age, gender, and ethnicity. It captures GP consultations, so recording symptoms, diagnoses, prescribed medications, and referrals to secondary service. And at the time, there was 674 registered practices, with 60% of the English practices participating in a linkage scheme. So this gave us the opportunity to link across multi-agency databases, including hospital episode statistics, ONS for death registration details, and index of multiple deprivation score, which gave us an indication of a social, demographic and economic data within that GP practice area. Next slide, please. So we extracted electronic patient records of those adults aged 65 years and over, and recorded their first event of self-harm occurring between January 2001 and 2014. Next slide, please. And self-harm was defined using the NICE guidelines of any act of self-poisoning or self-injury, irrespective of motivation. And we use this definition, sorry, could you just go above? We use this definition to, because of the classifications such as non-suicidal self-injury and suicide attempt, have to establish an intent of the behaviour. So it's very difficult in primary care records to quantify that. So the self-harm episodes were therefore from a spectrum of events from milder forms of non-suicidal behaviour to near fatal attempted suicide. Next slide, please. So during this observational period, we found the incidence of self-harm of the overall rate was about 4 per 10,000. The rates were similar among men and women, and we looked across that over the 13-year period, and they were stable. There was increased incidence with age. Could you just click enter and it will highlight certain areas? That's right, thank you. Incidence increased with age, and as indicated by the rate ratio, incidence was 30% higher in those 75 to 85 years and 80% among those 85 years and over compared to the younger age group. We also saw an increased incident in the most deprived social economic status, with 20% higher incidence compared to the least deprived. Next slide, please. So looking at the clinical management within the first 12 months of incident, there was a low percent of adults actually referred to mental health services of just under 12%. So could you just click enter, please? And although females were, more females were referred than males at 13 versus just under 10%. In addition, we calculated the likelihood of referral comparing the different social deprivation levels, and we found that older adults from practices in most deprived areas were 33% less likely to be referred. So if you just click, you can see also that the rate of referral was much lower within those most deprived areas. Next slide, please. So a greater proportion of females were prescribed a psychotropic medication than males, and they were more frequently prescribed to individuals in the youngest age group versus the oldest age group. Next slide, please. So looking at the psychotropic prescribing by medication type, and this is in the year following the self-harm episode, we saw more females than males were consistently prescribed more of this medication type. Can you click, please? Also to note was the worrying tricyclics prescribed, which are against NICE guidelines as into the do not do recommendations. And in bearing in mind that 80% of our cohort, the first self-harm event was from self-poisoning, these antidepressants can be potentially dangerous in overdose. So that's something to be mindful in terms of the consultation and careful prescribing. Next slide, please. So there were a total of 908 deaths in the self-harm cohort. And when we looked at mortality risk, we found that those older adults that had harmed themselves were 20 times more frequently estimated to die from an unnatural cause than those that hadn't got a record of self-harm, and 3 times more frequently in subsequent years. Although there were only 48 deaths by suicide, there was a markedly increase of suicide risk across the study period of 145 times greater risk to die by suicide following self-harm. Next slide, please. So in summary, in the 12 months following first event of self-harm, there was a high risk of 20 times greater of dying from an unnatural death. There was only 12% of those reporting a self-harm were actually referred, and lower referral rates were evident in the more socially deprived areas. There was also high rates of prescribing with psychotropic medication, and with over 80% of self-events being an overdose, there was this high level of this TCA prescribing, which is potentially dangerous in overdose. So in primary care and GP practice, where older people potentially consult more often, there's a real opportunity for earlier intervention, and GP should be careful in prescribing, increase support following an episode of self-harm or any other health conditions. Next slide, please. So, as I said, that this data is all primary care database, and we're very reliant on what's actually recorded if the patient's actually consulting with their problem. So I just wanted to draw your attention to other important research within the area. And Trier and colleagues at Kew University have published some great work looking at self-harm in older adults, including a systematic review reporting global rates and reporting risk factors of self-harm repetition. Can you click, please? And also published a qualitative study reporting on potential stresses reported by older people, which included loss, bereavement, loneliness, interpersonal problems, and comorbid health problems. Next slide, please. And this also led to a paper on the role of primary care in supporting older adults with a list of recommendations to support management. Can you click, please? So among them were basically considering self-harm in older adults, being responsive to distress, having time to follow up, extending consultation times so that if they're presenting with a health issue and then it comes to light about self-harm, there's more time to consider those. Consider patient medication safety and prescribing, liaising with third sector and social services, and considering this social network support. Next slide, please. So these management tools tie nicely into the NICE guidelines. We've already heard a little bit about those in terms of every older patient needs to be assessed because the intent's there until proven otherwise. Also adopting the same principles for younger adults, but particular attention paid to potential presence of depression, cognitive impairment, and physical ill health, and have this full assessment of their social and home situation. And again, there's this update that's coming out on the 7th of September. And within that, on the consultation, draft consultation section, it does actually mention loneliness and isolation, which is a really good step in the right direction. Next slide, please. So hopefully I've given a brief overview of some of the epidemiology of self-harm. I know it's not exhaustive and it's based in the UK and primary care, but it really gives us the opportunity for that early intervention to try and improve management and outcomes of older age people. Thank you.